So I want to thank everyone for a very exciting and interesting morning, and now I'm going to turn it over to David Seltz and get us going on the afternoon.
Great. Thank you, and good afternoon, everyone. For this afternoon, we're going to have our final witness panel of the two-day cost trends hearings, focusing on the issue of mandated nurse-to-patient staffing ratios. I'm just going to provide a brief introduction, and as I do that, I would ask our two expert presenters to come to the panel. So consistent with the HPC's statutory mission to examine healthcare cost drivers and issues that impact healthcare cost, quality, and access in the Commonwealth through these two-day cost trends hearings, we identified mandated nurse staffing ratios as a particular area worthy of further examination. In our 2018 pre-file testimony question, a majority of stakeholders did identify this issue as an issue that may impact the state's ability to meet the healthcare cost growth benchmark. We conducted an independent research analysis into this issue. That full research analysis and presentation was presented to the Health Policy Commission's Committee of the Market Oversight and Accountability Transparency Committee 2 weeks ago. We had a great discussion at that point. The full presentation that was presented at that committee is available on our website, and there's a link here in this presentation, which will also be online. So for today, before we really want to turn to a panel of witnesses to go into further depth in talking about what the potential impacts may be across a variety of different domains, and we're pleased to have a really incredible expert panel with us today, reflecting a diversity of viewpoints and perspectives on this issue. So before we turn to that really great panel, do want to provide an opportunity for a brief presentation that will summarize the HPC's research in this area. This is an abridged version of the presentation that was provided 2 weeks ago, and kind of summarizes some of the key points, but encourage people again to go to that full presentation for more of the full background. This next slide just talks about all of the different areas of examination that were included in our research and analysis. I won't walk through all of this, but this does roughly is consistent with the arc of the presentation you're about to hear. And we're so pleased to have Dr. Joanne Spits here with us in person today. Thank you for being on the phone at the committee meeting here from California, as well as Dr. David Auerbach, our research director at the Health Policy Commission. These are two of our nation's leading experts on healthcare workforce issues. And we're so grateful to have you both here today to talk about the research and analysis on this particular issue. So with that, I'm going to turn it over to the panel, and I'm going to just walk around and give you the clicker.
Okay. I will thank you for inviting me, and I will begin by talking a little bit about California's experience and then pass it on to Dr. Auerbach to talk about the Health Policy Commission research analysis. As you know, California has had minimum nurse-to-patient staffing ratios which were passed in 1999 and then implemented in 2004. There are some differences between the California law and the Massachusetts proposition or ballot question, I believe is the term you use here, that are a little bit different than what's in the California regulations. The California law that passed in 1999 was an Assembly Bill 394, and that bill did not itself specify ratios for each unit. What that bill did instead was direct that our Department of Healthcare Services would establish ratios that were then developed through an administrative process that took a period of years. The ratios were put forward in early 2002 and then implemented January 1st, 2004, with various ramp-up steps along the way, with the final ratios kind of for different units ramping up over time. The Massachusetts ballot question would specify the ratio specifically that would be required for each unit, which is an important distinction. In California, presumably, there could be a regulatory process to make changes in the future, and I'm not sure with the ballot question what that process would be with the difference in the way it's been put forward. There are also differences in the specific ratios that are in effect now in California versus what is in the ballot question in Massachusetts. In many cases, the Massachusetts levels would be more strict. For example, California has a 1-to-5 ratio for medical surgical units, and the ballot question has 1-to-4 proposed for medical surgical units. California has 1-to-6 for psychiatric, and the ballot question has 1-to-5 for Massachusetts, for example. So there are some differences in the specific ratios. In California, hospitals are allowed to use licensed vocational nurses, which are the equivalent of your licensed practical nurses, to fill in about up to 50% of the staffing requirements, whereas that is not in the proposed Massachusetts initiative. The Massachusetts proposal prohibits any reduction in healthcare workforce staffing of other types of professionals as a result of the patient assignment limits for registered nurses. That's not included in the California law. California allows flexibility for rural hospitals in particular who can apply for waivers to be exempted from the regulations or for flexibility. That is not allowed in the Massachusetts question. In Massachusetts, the requirements could only be suspended in the case of a state or national public health emergency, while in California, the definition of emergency is broader to allow for differentiation from the regulation. And then the proposed ballot question for Massachusetts has specific monetary penalties of $25,000 per violation, which are generally stronger than the enforcement provisions in California. The enforcement provisions in California are less definitively specified. Oh, no, there we go. So what has happened in California as a result of this? There's been a lot of research conducted about the California ratios and a number of review articles that even summarize that literature and some book chapters in nursing textbooks, nurse policy textbooks. So California at this point is the only state with mandated specific ratios in the United States. And in the 14 years since those ratios were implemented, I would say the 4 key takeaways are that first, there was a significant increase in registered nurse staffing as a result of the ratios in California after the implementation compared to before. Second, there was a moderate effect on registered nurse wages afterwards, which would come straight from labor economics. If you increase demand, the wages should go up. Third, that there was no systematic improvement in patient outcomes after implementation of the ratios. And fourth, there was no comprehensive or retrospective analysis of what the costs of the implementation were. So nobody did that study. It was not done by the state, and it was not done independently. So we don't know what the financial impact was in net statewide. And so now I hand it to David.
Okay, thank you, Joanne. Okay, so with that background as helpful context, let's go through fairly quickly what we did and what we found an analysis of this in Massachusetts. Am I on? Can you hear me? Yeah, okay, great. All right, so a couple of slides of background. First of all, it's important to understand where Massachusetts levels of staffing are compared to the rest of the country and compared to California today. This is data from 2016 showing hospital staffing levels in Massachusetts, in all of the states, per 1,000 inpatient days. So this is an aggregate measure of all RNs working in hospitals. And it shows that we are roughly similar to where California was in 2016, a little bit higher and above the United States average. We next surveyed a number of quality measures to try to get a sense of where is quality in Massachusetts, especially quality where the measures are related to nursing and nurse staffing levels. So these are the 6 nurse staffing, nursing sensitive quality measures in the state data from 2015, and we're showing that compared to California, Massachusetts hospitals performed pretty well, better than the California average on 5 of the 6 measures, and lower than 1 on most of them, which means the hospitals are performing better than expected. And on the last measure is a little bit different, where it's a voluntary reporting, not mandatory for all hospitals in Massachusetts. So that's sort of a smaller sample size on that measure. And these are measures for all patients in Massachusetts. There are a few measures reported by CMS for the Medicare program, and on these, pressure ulcer rates, hospital falls, we are similar to California, and then that measure on the right is a composite measure consuming 10 different similar types of measures, and on that composite, we are also a little bit lower than California's average level. Okay. So with that as background, I'll now go over quickly what we did in this analysis. We benefit from the availability of detailed data on nurse staffing at the hospitals by unit, even by shift, for the number of units that are shown there on the top. And this data wasn't available in California before their ratio. So this makes analysis much easier. It's not perfect, of course, but this data is called Patient Care Link, and you can see there the units of the hospitals included in this data. And not only does it have nurse staffing levels in these units, but it also has patient volumes. So using this data, you are able to compare the levels of staff per patient and compare those to the ratios that would apply. So we went through this exercise for all hospitals available and compared those staffing levels to the ratios. Now, it's important to note that these are average levels of staff throughout the year. And if a hospital has an average level of staff or a nurse-to-patient ratio that is the same as the mandate, that's still probably not going to satisfy the requirement, because sometimes those averages fluctuate. Sometimes nurses are away from the floor for a break or for other reasons. Sometimes your patients surge, and so those ratios will fluctuate up and down. But the mandate says you must meet those ratios at all times. So starting with that point of what are average staffing levels, we had to think about how much more does a hospital unit have to staff above that average to meet the mandated ratio at all times. So you'll see that in the estimates to come that we made, because there's uncertainty in that, we made two different assumptions, and those are called scenario A and scenario B on that measure. We also estimated an impact for standalone psychiatric hospitals. We estimated an impact on RN wages across the state, as Joanne mentioned, based on evidence from what happened in California. And we considered additional costs, such as one-time costs to set up the acuity tools and possibilities of cost savings from the increased staffing that would result from the mandate. Okay, so to summarize the results on the metric of how many more nurses would be needed to meet the mandated staffing ratios. I'll go through this slide. What you see in the left column is strictly a comparison of those average staffing levels to the mandated ratios. And what that's showing is that for these hospital units we looked at, about 34% were staffing under the mandated level on average. And if you only had to meet those averages, you would need about 1,100 more RNs, or about 8%, given this base of hospital RNs that we started with in the data. Under analysis A, we assumed that hospitals would have to staff 10% above those mandated levels to meet the at all times. And those assumptions were informed by discussions with experts and other folks who weighed in on that question. So under analysis A, about 46% of the hospital units would need to increase their staff. Under analysis B, which was a 20% cushion assumption, about 54% would have to increase their staff. And you can see the number of RNs required under each of those analyses. We also looked at staffing in standalone psychiatric hospitals, as we noted, and using we didn't have as detailed data there, but using other data, we estimate that you would need another 477 RNs in those settings, resulting in, on the bottom, an addition of about 2,200 to 3,100 under these two scenarios, new nurses needed to meet the mandates. And I'll show a little bit about where those needed nurses would break down, because there's some important differences. For example, in community high public payer hospitals, they would have to increase staffing the most. 21% under the scenario A and by 30% under scenario B. The AMCs, the academic medical centers, would need to increase less, 5 to 7%. According by the time of the shift, the night shifts would have to increase their staffing more than the evening and the day shifts. And by type of unit in the hospital, about half of the new RNs would be deployed in medical surgical units, which are the most common, but there would be significant increases required in the labor and delivery units as well as in the psychiatric units. Okay, so that's the increase in the number of RNs. We also looked at this potential impact on RN wages across the state. As Joanne said, there would be an increase in demand for nurses, and that would bid up the wages that RNs are paid. Studies from California using 5 separate independent data sources found that average RN salaries in the state rose about 4% more than they did in other states over the same time. And they attribute that to the effect of the mandated ratios itself. So we use that as a benchmark. The impact on Massachusetts could be greater. Our ratios are stricter. There are monetary penalties. You can't substitute other nursing staff. Those are all reasons that the effect could be larger in Massachusetts. California did have a deeper nursing shortage at the time than other states. That's the reason it could be smaller. Taken together, we estimate that in analysis A, that about 4% is probably a good estimate of the effect we might have in Massachusetts. Under analysis B, we use an estimate of 6%, accounting for those other factors, and then you'll see those reflected in the final costs. It's important to note also that these wage increases wouldn't take place overnight. People have contracts, it would take a while. So our estimates should be interpreted as a long run, a 2 or 3 year effect that would occur every year. Okay. So here's the final analysis of the cost, although there will be more on the slides to come of additional factors that we couldn't put into this cost estimate. And here it's broken out by a number of categories. You see cost for acute care hospitals broken out by hiring of those additional RNs. Under analysis A and analysis B, there would be costs of those wage increases for their existing RN workforce. As we mentioned, that 4% or the 6%, that's applied to all RNs. And costs for ongoing use of these acuity tools. The additional costs there are noted for the psychiatric hospitals, and there would be costs for other settings, such as physician offices who also employ RNs, shown there, and additional costs to the Commonwealth, with a final tally of about $676 million under analysis A per year, and $949 for analysis B. And note that these estimates, as I'll show, exclude some things that we could not analyze, so there are additional costs that are probably would be felt that are not in these numbers, and that's why this is a conservative estimate. So of those costs not included here, shown on the next slide, there's been a lot of talk about emergency departments, and we'll add some more detail on that in the next couple of slides, but we did not have detailed data there. Outpatient departments, we were not able to estimate in observation units as well, where the mandates would apply. There could also be costs in non-acute hospitals. There's some ambiguity of whether the mandate would apply there. State agency implementation costs and penalties for noncompliance. Those are other areas of potential cost. And there would also likely be some one-time costs that we didn't specifically account for in our estimate, but costs to purchase the acuity tools in the beginning. And there could be some workforce type turnover costs if some of these RNs are pulled from other jobs in the state, where those organizations would then have to recruit and hire someone else to backfill that position. Okay, so again, based on our last presentation a couple of weeks ago, we were asked to provide a little more detail on what might happen in the emergency department. So here's some additional data. The mandated ratios do apply in the ED. It is based on patient acuity. So the ratios range from 1 to 1, one nurse to one patient, to 1 to 5, one nurse to 5 patients, depending on the patient acuity. And that's the main reason we couldn't do the same level of detailed analysis, because we don't have data on patient acuity. We also don't know how long those patients spent in the ED, but we do have tallies of the numbers of RNs in these ED settings and the total numbers of patients, which I'll show here. We identified in the patient care link data just over 3,000 RNs working in EDs. And compiling that data, the average worked hours, RN hours per patient visit ranged from about 1.38 to 2.28 at the 10th or the 90th percentile by hospital. So here's just for illustrative purposes, if it were the case that you needed to increase your RN staff at the same level we found in the other units we analyzed, which was about 15 to 20%, that could add 79 to 110 million cost. So that's just an extrapolation, and that is not in our formal estimate, because we really can't estimate with great confidence what that increase would be. Qualitatively, there could be other impacts on the emergency department, which the panelists will probably speak to. You could have impacts on access to emergency care, impacts on wait times, on patient flow, on ED boarding, on ambulance diversion. And to further inform this, we did reach out to stakeholders to see what else we might learn between our last meeting and today, and we were provided with a couple of pieces of information. One from the Mass Nurses Association here, a paper from 2017, a study that did find a relationship between nurse staffing levels and ED wait times. And the reference you can find at the bottom of this slide. And the MHA did provide us with their own cost estimate, or the College of Emergency Physicians. And we didn't include those numbers, but you can also find that in the citation there for what they estimated it would cost in the ED. Okay. We also looked at the possibility of cost savings. There is a broad literature finding that levels of nurse staffing do relate to some patient outcomes, including length of stay and adverse events, in the direction you might expect. Higher staffed hospitals have lower lengths of stay and reduced adverse events on average. And these papers suggest that there would be something on the order, at least one paper from 2006, of about a $15,000 savings on these measures and others per RN hired. If you extrapolated those results to our workforce increase that we estimate here, that would range from about 34 to 47 million in savings if we were to realize that. It's unclear if we would. And that's from extrapolating the results from those studies to Massachusetts. You don't quite see the same level of outcomes in California. It could be that mandating those ratios don't get you the same effect of just comparing a highly staffed hospital to a lesser staffed hospital. So there are some issues with causality, but that's the range of savings to give you an order of magnitude that's associated with this level of RN increase. There are also papers finding reduced RN turnover rates and reduced workforce injuries from higher levels of staffing, and those are findings from California. And again, those papers can be found here, and those could result in additional cost savings. Okay, just a quick note on, it's been asked, if hospitals do have to staff up, where would they get those RNs? And the answer is there's a number of sources, and we don't have confidence as to how the distribution would work across these places. But you can imagine, and based on what happened in California, RNs could be recruited from other positions within the state, from hospitals, from non-hospitals. You could increase your numbers of new graduates. Hospitals would surely make use of RN staffing agencies and hiring temp and traveling RNs as an easy way to get RNs, at least in the initial set. You could have RNs coming from other states or other countries, and you could also just get more hours out of your current workforce, delaying retirement or having RNs convert from part to full-time, for example. Okay, and finally, just to think about what's the implication of those levels of cost that we talked about? What would that mean for the healthcare system? How would hospitals deal with a cost increase like that? They would probably do a number of things that, across these margins of adjustment. For example, they could use some of their assets. Their margins could be lowered. They could reduce capital investments that they currently make. They could choose to close unprofitable service lines. And they could reduce their non-healthcare workforce staffing levels. The mandate does not allow them to reduce other healthcare staff. To the extent that hospitals are able to negotiate higher premiums or higher payment rates from insurers because of the mandate itself, some of those costs could translate into higher premiums. It depends on that. And then just to give a general sizing of these costs, that represents about 1.1 to 1.6% of total healthcare expenditures in Massachusetts in 2017, and about 2 to 3.5% of hospital spending. Okay. So again, the fuller analysis is available in the online presentation, which includes side-by-side comparisons of the different estimates of this mandate and showing how we made different assumptions from other groups, which you may hear about today.
So thank you, David. Thank you, Joanne. Are any comments or questions that the commissioners have of our two experts?
David, I just have one question. I'm just looking at the slide. When you asked for comments back from proponents and opponents, was the only information that got back about the study related to the emergency room, or were there other comments about the study that were provided by the proponents and opponents?
Here I'm referring to just what additional information we learned about the ED specifically. I mean, we've received information throughout the process in various ways that we've sifted through and incorporated when we felt it made sense. Is that a fair reflection? Yeah.
I have a question, Joanne. I was curious. In California, one of the many differences between the Massachusetts and California is the fact that the legislature gave it to a first of all, it was a 5-year spread between the passing of the legislation and the ultimate. But I'm curious about how the process worked in terms of did it bring in stakeholders? Was it a serious discussion? Was flexibility brought in? You know, I mean, this idea of the mandate, you know, so many, I can't tell you the number of people have came to me and who legitimately wanted to do the right thing and said, we have no idea. Why are you asking voters to make this kind of a complicated decision? So I'm curious about the alternative, what it might have looked like had we done it the way California did. How did it work?
So the Assembly Bill 394 passed in 1999, and that then charged the administration with developing what the ratios would be through the Department of Healthcare Services. They received, I don't know that they necessarily solicited it, but the various stakeholders did put forward their recommendations. The California Hospitals Association had a recommendation. I believe Service Employees International Unions branches and health workers in California had proposals. The California Nurses Association had proposals. The proposals were all, of course, not surprisingly, pretty far apart from each other. I think the Hospital Association recommended a minimum of 1 to 10. And I believe the California Nurses Association recommended a minimum for medical surgical of 1 to 3. So they, you know, had a pretty broad range there to work with. Another piece worth noting for California, 2 other pieces, is that California had ICU ratios in place already for at least 20 years. In fact, I have never been able to find the exact date. It happened after I was born, but way before this passed. So those had been in place for so long in California that nobody even really knows how that happened. And California also already had an acuity system in place, although the acuity system did not have any very clearly stated standards or enforcement mechanisms around it, really. So it was viewed as not necessarily a successful system to the fullest potential. But that may have provided some backdrop. So the Department of Healthcare Services then also received research. We did a study at UCSF sponsored by California Healthcare Foundation, and they commissioned a study that was done by Kravitz and Romano at UC Davis. And they had a more extensive opportunity to get data directly from hospitals through random audits. And we all kind of independently provided estimates of what the number of nurses might be and so on. And somehow through that process, draft ratios were put forward. They went through public comment processes like any draft regulation would. And eventually the regulations were finalized in 2002 with an implementation start in 2004. There were a series of lawsuits that happened through there, and all of the gory details of those I have in a book chapter that I wrote that I'm happy to share. But eventually, the lawsuits ended with the ratios being upheld and fully implemented for the most part by kind of March 2005.
One other, and then I'll, the flexibility that got built into the final in terms of allowing some staffing by non-RNs and so on, was that in the original proposal, or was that part of that whole process?
That was largely part of the process. If I recall correctly, the Assembly bill focused on licensed nurse-to-patient ratios, and the Department of Healthcare Services, I believe, would have had the prerogative to make a statement about RNs versus LVNs if they so chose. Our scope of practice for LVNs is very restrictive, so that in practice, there is very little opportunity to have 50% of your nursing staff be LVNs.
Okay. Anybody else want to? Again, I want to thank you, Dr. Spits, for coming from the nice state of California, and particularly want to thank David and his staff for really a job well done. So thank you very much.
Thank you.
I'm now going to turn the program over to my colleague here, Wendy Everett, who is going to then introduce the panelists and so on. So if the
Wonderful, thank you. If the panelists would take their seats, we'll take just a moment to have them be sworn in. Thank you.
Long time to see.
Thank you very much. I was just informed that you do not have to be sworn in. I'm not sure what privileges that gives you. But consider yourself lucky and blessed. So with that, I just want to add my thanks, particularly to Joanne and David for giving us such a good prelude to this panel. If we think back to this morning's very genteel, mellow, and uncontentious discussion about pharmaceutical costs, I'm sure, vodka tonic. I'm sure that this panel will be just as interesting. And my thanks in particular to each of you for giving us your time, your thoughts, and your attention today. We really want to spend the next hour better understanding how this nurse staffing ratio ballot initiative is going to affect the cost, the access, and the quality of care for the Commonwealth. As you all know, certainly cost and the control of the cost growth curve in the Commonwealth is the sole charge or one of the major charges of the Commission. So we want to build that discussion off of the data that you each have collected in your own work, off the data that has come out of the experience in California, and off of the analyses and the data that David and his team has collected. So I just want to kind of reconstitute what the Attorney General said today in her comments, which is we really are here to plan for the future. And we want to do that in a spirit of working together, understanding that we're going to have disagreements and that there will be challenges in those planning efforts. But I really do want to set that tone for the discussion this afternoon. So I have two caveats before we introduce each of you. The first is that I'm sitting here, as Stuart said, moderating this particular panel. I do have an evil twin. That evil twin is the timer on my phone. It goes off at 3 minutes. So when you were instructed that you had 3 minutes to do your opening remarks, the secretary and I will thank you together when the chime goes off, and we will move to the next person. That will allow the commissioners to have an opportunity to really engage in discussion with you and get a much better understanding of your perspectives. And secondly, I do want to invoke my New England grandmother and once again say that when we disagree today, we will disagree very respectfully and with great admiration for the work that we've done. So beginning there, I'm going to quickly introduce each of the panelists and then have you come back and start, Judith, with you with your presentation. So first we have Dr. Judith Schindel-Rothschild, who is the Associate Professor at Cornell School of Nursing at the Boston College. Connell. It says Connell, and I misread it. Thank you. See, I have a partner. Second, Vicki Bermudez, who is a regulatory policy specialist and is here at the request of the California Nurses Association. Third, Dr. Joanne Spits, who has been introduced. Fourth, Dr. Nancy Gaeta from Boston Medical Center. And fifth, Deborah DeVoe, the Chief Operating Officer of Blue Cross Blue Shield of Massachusetts. So welcome to each of you, and I'm going to call you by your first names just because everyone has long and unpronounceable last names. You may call me Wendy. So Judith, would you begin, please?
It is indisputable that better RN staffing levels lead to better patient outcomes and greater value, especially for high-risk patients. In my opinion, this added value was not adequately reflected in the HPC cost report. Total RN FTEs cited in the HPC cost report includes both direct care RNs and nurse managers administrators. There is a highly significant difference in direct care RNs between California and Massachusetts hospitals. Massachusetts hospitals staff with 3.5 hours a day less of direct care RNs and 5 hours a day less of all hospital unit staff than California hospitals. California hospitals allocate 5% more total budget, personnel budget to RNs than Massachusetts hospitals. 9 Massachusetts hospitals that have the worst RN staffing account for half of the estimated increase in costs for the additional RNs. These 9 hospitals had a combined profit of $224 million. Wage costs. 66% of RNs employed in Massachusetts hospitals are part-time compared to 40% of RNs in California. In 2016, half of all new hires in Massachusetts hospitals were new RN graduates. There is a sufficient RN labor supply to meet the HPC's estimate of additional RNs if half of the new baccalaureate graduates are hired and 10% of the part-time RNs are hired full-time. There are 27,000 RNs employed in acute care hospitals. The M&A collective bargaining contracts for the next 3 years have an inflation factor of between 0.5 and 2%. The HPC report wage inflation costs should be more modest given the current supply of RNs, recent history of new hires, using an 80,000 RN base, and the fact that 65% of staff nurses are under M&A contracts. The HPC estimate on additional ED RNs appears inflated given the findings in my cost analysis and my published research on RN staffing and ED wait times. Quality. A substantial portion of the CMS penalties incurred by Massachusetts hospitals were due to readmissions. My research comparing readmission rates in California and Massachusetts hospitals found nurse staffing was a significant factor explaining the difference in readmission rates between the two states. In 2018, Massachusetts hospitals, meeting the staffing standard of Question 1, on average, received $500,000 in bonuses from Medicare for good patient outcomes, while Massachusetts hospitals with the worst RN staffing were penalized $500,000 due to poor patient outcomes. Ideally, market-based incentives in Massachusetts would entice hospitals to allocate a sufficient proportion of every hospital dollar to direct care RNs to improve patient outcomes. But as the unprecedented action by 24,000 staff nurses who put Question 1 on the ballot signifies, in too many hospitals, these market incentives have failed. Passage of ballot Question 1 will force a change in that equation.
Thank you very much. Vicki?
Good afternoon. My name is Vicki Bermudez, and I have worked as an RN for 50 years. I am a regulatory policy specialist for the California Nurses Association and NU, the proud sponsors of the landmark patient protection legislation. After extensive research, the leanest staffing for every nursing care unit was adopted nearly 15 years ago by the Department of Health Services. This limitation on how many patients any RN could be assigned leveled the playing fields for all hospitals so that every patient would receive the protective surveillance of an RN with an assignment that would allow time to provide quality professional care. The patient classification system, implemented in 1997, was to be used to increase staffing based on patient care needs. The DHS selected a research team that included 2 doctorally prepared UC Davis RNs. That research team assembled an expert panel of registered nurses who identified 9 quality indicators for later evaluating the new California staffing standard. The indicators in Dr. Spits' presentation were not among the 9 indicators selected for validity, feasibility, and overall suitability for later evaluation of the ratios. In fact, 4 of the indicators were identified as unacceptable. 2 years after implementation, California's staffing and patient care outcomes were compared to those in 2 other states using 2 of the expert-selected indicators. The comparisons revealed that California nurses cared for fewer patients than the other 2 states. The better staffing demonstrated significantly lower mortality. If the average ratios in both states had been equivalent to California's, there would have been between 10 to 14% fewer surgical deaths for patients in those states. A study using another indicator, occupational injury, revealed a 30% reduction in occupational illness and injury for hospital nurses per year than the expected rate without the law. In a March 2018 interview on the subject of nurse staffing and patient outcomes, Professor of Nursing Dr. Linda Aiken, who is generally considered the nation's foremost expert on nursing workforce, stated, quote, "One of the best natural experiments occurred when California enacted mandated nurse-to-patient ratios. When it was implemented on January 1, 2004, the hospitals that were not in compliance to the staffing ratios had to change on that day, and they did. Our research has shown that staffing did change substantially in California, even in safety net hospitals, which have been very difficult to get to change on hospital staffing. Almost 15 years later, California still has the best nursing staffed hospitals in the country. The state has been seen steeper declines in mortality and improvements in other indicators other than states," unquote. Thank you for inviting CNA and NU to be here today to talk about our nurse staffing.
Thank you very much. And it's, I think, particularly helpful to have both of your testimonies, because one of the things that the commissioners want to understand is the differences between what happened in California and what potentially might happen here. So I'm going to turn to Joanne and have you take a moment and potentially respond to some of the analyses and data from the first two speakers.
Sure. Hi, I'm Joanne Spits, and we've already been introduced.
Yes.
Let's see, in thinking through and just briefly responding to the two presentations thus far, I think two things are going to be very important to keep in mind. One is the difficulty of trying to attribute any changes in outcomes causally to changes in regulations. Dr. Aiken's work was quite excellent, and I'm actually an author on that paper. It was excellent paper. It wasn't
Okay.
But it is stated also in that paper in its limitations section that it was a cross-sectional analysis. So that study was all based on 2006 data, post ratios, and while it did show that indeed staffing was better in California, it could not say that improvements in patient outcomes were strictly due to the regulations being implemented. That was correlational, and that is stated in the paper by the authors directly. And that is one of the difficulties with all of the research. The papers that have tried to use approaches that identify causal relationships have found no consistent patterns with the data that are available, which may not include every indicator that would be pertinent, and that is stated as a limitation in those studies. And because the ballot question in Massachusetts does have different ratios, timelines, and processes than California, you could get different results in Massachusetts than what we saw in California. Regarding direct patient staffing, I think Dr. Schindel-Rothschild is absolutely correct that direct staffing is more important than total staffing, possibly. Unfortunately, there is no good, consistent data source for that nationally. The American Hospital Association data, which I assume is what she looked at, has a direct care measure, but it is reported for only about half of the hospitals in California and only about half in Massachusetts. So I don't know what the non-response bias is, and if one tried to adjust for that non-response bias, I'm not sure what differential we would see or if the patterns would be the same, which is why for the report that Dr. Auerbach's team did for the Health Policy Commission, they used the most reliable measure that was available for all hospitals.
Great, thank you. Thank you for responding, and I realize you may have had some other remarks that we can come back to. Nancy, thank you.
Thank you for the invitation to testify today. My name is Nancy Gaeta, and I'm the Chief Nursing Officer at Boston Medical Center, an academic medical center serving the patients that are the most vulnerable in our region. Over half our patients are insured by Mass Health or are uninsured. I've been a nurse in Massachusetts my whole career. I have more than 20 years' experience in nursing administration and have been the Chief Nursing Officer in both teaching and community hospitals. As the CNO, I am responsible for both the quality of care and overseeing a staff of about 1,600 registered nurses. I'm alarmed at what would happen if question 1 passed and what it would mean for the delivery of care at my hospital and at all hospitals across Massachusetts. I'm going to walk you through what the passage of this proposal would mean to access to care at Boston Medical Center. Our calculations are consistent with those described by Dr. Auerbach, and our concerns, I think, are illustrative of what we could expect to see statewide if this passed. We already have a nursing shortage in Massachusetts. There are about 5% vacancy rate across the hospitals, which translates into about 1,200 registered nurse openings. To look at the impact of question 1, if it passed, I began by analyzing the Boston Medical Center Emergency Department. We see about 350 patients a day in our ED, making it the busiest ED in Massachusetts. This bill would require us to hire 52 additional full-time nurse equivalents in our ED. And until we could hire and train the 52, and we would be competing with the entire state for those nurses, there would be up to 104 patients every single day who would not be able to be cared for inside of our emergency department. It is unimaginable to have 100 people a day never getting into the care area of our ED. Instead, they're in our waiting room. They would be spilling into the hallways and outside while the staff tries to figure out who to care for. I cannot think of a safe way to address this. In our labor and delivery area, where I would need about 20 additional nurses, my only option would be to close 1/3 of our labor and delivery beds. That would mean that up to 800 mothers a year would be unable to come to Boston Medical Center to have their baby. And I think they would have to go to Rhode Island or Connecticut or New Hampshire, because every single other hospital in Massachusetts will have this same issue. At BMC, we've estimated that we would need 92 additional nurses for our regular medical surgical floors. If this bill passes, I would not have enough nurses. So again, I would have to close beds. We would, of course, prioritize the patients in the emergency department who needed to be admitted. So I think our only option would be to turn away elective admissions. They are primarily surgical patients, but would absolutely include transfer requests from other hospitals. Our calculations of the additional number of nurses we would need in every area at BMC are consistent with the Health Policy Commission's findings. This is an enormous threat statewide to access. There's been a great deal of focus on cost, but truthfully, that's not my biggest worry. I'm gravely concerned that we would have to substantially limit the care that we could provide.
Thank you,
Thank you very
and
much.
we can come back to your discussion later, but thank you, and we were serious. Deb, nice to have you here.
Thank you. Good afternoon. I'm Deborah DeVoe, the Chief Operating Officer for Blue Cross Blue Shield of Massachusetts. We serve nearly 3 million members and more than 39,000 accounts as their health plan. Our purpose and our responsibility to our customers is making quality health care affordable. To do
Deb,
this-
if I could interrupt you, would you just bring the microphone closer,
Yes,
please?
thank you.
Thank you.
Thank you. To do this, we focus on cost, quality, and access to services for our members. The focus of this panel, we recognize that there are strongly held and widely differing assessments of the cost and impact of the proposed mandated ratios. We believe that a process that involves all of the stakeholders coming together to address the goal would yield the best result. The ballot question doesn't allow for this process to occur as a way to work through these differing views. Having said that, I will provide our assessment of the proposed ballot question. 3 organizations have issued reports on the potential cost and impact: the Health Policy Commission, the MHA, and the Mass Nurses Association. We've examined each of these reports, focusing on 5 key questions. What is the goal of the new mandate? Does the proposed ballot question achieve that goal? What will it cost? How will the cost be funded? And is there potential for impact on access to care for patients? I'll give our observations on each of these questions. The goal, as we understand it, is to improve patient care. Does the ballot question achieve that goal? There's not agreement across the stakeholders that the mandated nurse staffing ratios, as proposed, will improve quality. What will it cost? The 3 reports have all concluded there will be a cost increase if the ballot question passes. The estimates of this increase vary widely. One report, the HPC's report, has estimated the cost impact at up to $1 billion. For Blue Cross, any significant increase to cost without clear, predictable increases to quality would be unsustainable for the healthcare system. Fourth, how would these new costs be funded if the proposed ballot is approved. This is an unanswered question with significant implications. Again, views differ widely. Some suggest that hospitals could absorb some or all of these potential new costs. Hospitals do not agree. Assuming that hospitals could not absorb new costs through existing payments, are the state and federal government expected to increase their costs and budget? Are employers and consumers expected to absorb increased costs through higher premiums, higher cost sharing? This issue and how the costs will be funded is of significant concern to Blue Cross. And finally, as we've heard in the discussion, a question about access has been raised. Could there be an unintended consequence of a decrease in access instead of improving care? We've heard the discussion on this question. This is not intended by any of the stakeholders, and if the ratios are passed, understanding whether access is affected is also of significant concern to Blue Cross. So in summary, our understanding of the proposed ballot question is there's not common agreement among the key stakeholders on whether quality of patient care would improve. There will be increased costs, and without clarity about how those costs would be paid for, this would be an unfunded mandate. Finally, there is potential for unintended consequence to access. We have a history in Massachusetts of bringing together the stakeholders in healthcare to tackle tough issues: healthcare coverage, access, and cost. Blue Cross has been, and will continue to be, an active and constructive participant in this work. We commit to the principle of shared responsibility with this commission and the other critical stakeholders to work to advance the goals of high quality and affordable care in our state. Thank you.
Thank you. Let me just follow up with one question before we open it up to the commissioners, and that is, as you looked at costs and analyzed those costs, understanding that it's an unfunded mandate at the moment, did you take it the next step and look at what effect this might have on premiums, on your insurance premiums? And maybe I'm preempting Rick here, but it would seem to me that it isn't just, we can't just declare that this is an unfunded mandate. We really have to take it the next step and say, what effect will this have on the Commonwealth? So were you able to take it that next step, and if so, what did you find?
We were not able to estimate the impact on premium, primarily because of the unanswered questions about whether the hospitals would be able to hire and employ the nurses necessary. So on one end of the continuum, if we believe that the hospitals would be able to do that, and again, the cost estimates vary widely, but the HPC has estimated that that could be up to almost $1 billion in cost, then we certainly anticipate that there would be some impact on premium. Over what period of time, how much of that would be borne by our customers was an open question. But on the other end of the continuum, and the reason that we really can't create a viable cost estimate, what if the hospitals cannot hire at the levels specified by the mandate? The costs would be lower. The impact potentially on those funding those costs would be lower, but then we've got an access issue. So we did not have a specific estimate of the impact on premium.
Great, thank you. Okay, let me open it. Rick, pick right up.
Yeah, so I'm actually not going to ask about the impact on premium because I do get the fact, I mean, to the extent that you can hire any of these additional nurses, it will be passed on at some point. But I had a question, I think, for Nancy, because you're on the front line, and if this passes on November 6th, you have to make decisions about where you're going to be on January 1st, right? Either hiring up, and whether that's even possible within that period of time, or shutting down units, right? And then I'm curious, I would love to hear back from Judith. You said there's enough nurses, there's enough supply to meet the demand required under this law, either with new nurses and hiring people who are part-time. So Nancy, I'd like to hear what you think about whether you can staff up in that amount of time, and then maybe Judith, you can respond as well.
Thank you. In 37 days, we could never staff up. We hire We are hiring constantly at Boston Medical Center. We hire new graduates and experienced nurses when we can get them every single month. 25% of the nurses we've hired this year are new graduates. There is a critical mass that you can manage on any given unit in terms of how many really new nurses you can have, and we've had to add other resources to be available for our new graduates on the night shift as it is. We've been growing at BMC, so we have been in a very high, fast-paced hiring momentum. You know, that's been our storyline for like about 2 years, and we are hiring as fast as we can already. The two particular areas that I highlighted in my opening remarks, the emergency department and labor and delivery, are very specialized. There are only so many ED and L&D nurses in Massachusetts. And to train a new nurse in those areas takes 6 to 9 months. So those two access sort of focused areas are my biggest worry. And so to be absolutely honest with you, if this passes, what I will focus on during November and December is closing areas.
Great.
So that I can meet the law.
Judith, did you want to respond as well?
Sure. So first, I'd like to clarify the language of the ballot, which is that, and I participated in the Citizens Initiative review process, and we were fortunate enough to have a representative there from the Department of Public Health. And he clarified for the citizens that it would not be in effect on January 1st. It would take 6 to 18 months, roughly what we did for the ICU law, to promulgate regulations. Secondly, as part of the language in the ballot question, it says that it would not take effect until the hospitals each come up with a plan approved by the Health Policy Commission. And third, the Massachusetts Nurses Association already, who represents most of the nurses employed in disproportionate share hospitals in the Commonwealth, has already negotiated extensions of up to 3 years on those contracts in anticipation of this ballot question passing, to give them a longer time. I would like to add about the disproportionate share hospitals, and I understand this is cross-sectional, but I think it's important to understand the differences between California and Massachusetts. Of those measures that were shared with the Commission, if you look at just disproportionate share hospitals, there is a significant difference in outcomes between our disproportionate share hospitals and California's, and the variance is huge. So while the average might look good between the two states, when you split out disproportionate share hospitals, there's a significant difference, and our variance goes way above what is in California. In other words, there's a more level playing field, as Dr. Aiken said, even for the safety net hospitals, in terms of the quality of care across the state. As far as the supply, I teach at Boston College, and we graduate about 100 nurses a year. We license in Massachusetts about 1,600 baccalaureate graduates. Those would be the first people who would be hired. These nurses would love to work in Massachusetts. The National Student Nurse Association does a survey every year, and the two states where new nurses are having a harder time getting hired are Massachusetts and California. Also, we have a much higher, as I said, part-time workforce. And we, too, have our graduates, we get anecdotal reports from them that they would love a full-time job in Massachusetts, but the full-time jobs just aren't there. So I really, honestly, given the concerns of our alums that we survey, don't see a shortage in this state.
I'm going to just take the prerogative of the moderator for a moment and, Joanne, ask you to just come back and comment on the disproportionate share issue that Judith raised, because the kind of obviously the Dish Hospital comparison is an important one, and one extremely important to another panelist. So if you would comment on that, number one. And then could I ask one of our fabulous legal people, just to clarify for me, and this may be my lack of knowledge, about the start date for this legislation, because I think most of us are under the impression that the regulations, the responsibility for the regulations being written would fall to the commission, and also that the start date would be January 1st, 2019. So if I am wrong in that, I'll put it on myself and no other commissioners, then that would be very important for us to know in our deliberations. So Lois, is there a way for you and David to kind of bring us up to speed and just pass me a note when you can? Thank you. And we're sorry for that little sidetrack, but there may be an answer. Let's give them one moment to caucus. Isn't that what lawyers do, they caucus?
Good afternoon. Just to, we're very careful at the Health Policy Commission recognizing that the law is not in effect yet and our duty to promulgate regulations is not yet upon us. But the text of the ballot question, as I have read it, says that the effective date is January 1, 2019. And there are provisions about different obligations of hospitals to form compliance plans and the like in order to comply with the mandate, but the effective date is written as January 1.
Thank you. Thank you.
Yeah, you asked.
I did ask a good question of Joanne. I just wanted to give our legal team a moment, and they were faster than I had anticipated. So thank you very much, and back to Joanne.
All right. You didn't ask, but I will briefly respond because it's come up a few times about how do you do this ramping up. California, of course, had more time to plan. But what we saw in California in the short term, because this happened for California in the middle of a very deep shortage of nurses nationwide, was a increased reliance on traveling and temporary nurses in the probably about 2 or 3 years post ratios. You saw the share of contingent personnel in hospitals went up a lot. And then as our nursing schools grew, and they had already been growing because of the shortage, as they kind of reached their maximum capacity, which was more than double where it had been in like 1998, then the share of traveling nurses gradually tapered down. So I would anticipate that that would be a strategy that hospitals here would logically pursue. And you probably saw the same thing, Vicki, when you looked at your data. So you asked about DSH hospitals. So some of those hospitals in California probably were among the group that had waivers if they were rural and small.
Right.
But the analysis that was led by Barbara Mark, who's a professor of nursing at University of North Carolina in a federally funded study, we focused on looking at differences in staffing changes between hospitals that were in the lowest quartile of pre-regulation staffing versus those that were, say, at the top quartile of pre-regulation staffing in California. And in the paper where we only looked pre-post and compared those ones that were low versus high, the ones that were low, no surprise, raised their staffing more, which would be consistent with the quote from Dr. Aiken. But we did not find that their patient outcomes increased simultaneously more with that, that would be correlated with that growth. Barbara also led a study that did comparisons of California versus other states, focusing on the high versus the low, and again, found no systematic quality changes. So I do believe that probably the regulations have evened up staffing across hospital types within California, but the patient outcomes results, as I said before, the research has been very inconsistent about what kinds of outcomes there have been.
Is
Great.
it possible
Thank
that
you.
I'm sorry, could I clarify about the rural hospital waivers?
Absolutely.
The rural hospital, I actually read every program flex requirement in California because I was a regulatory policy specialist and very involved in it. I also happen to have practiced as a nurse before the ICU regulations were ever adopted, after they were adopted, and then after the nurse-to-patient ratios throughout all the facilities are adopted. None of the rural hospitals had flexibility for the ratios themselves. It had to do with some of the language in terms of, for example, if you were in the emergency room and needed to have and there was a patient there, you needed to have 2 licensed nurses, 2 registered nurses, licensed nurses there at all times, that they were allowed to use, for example, a nursing supervisor who wouldn't be physically there, but that could be called immediately. So that was the kind of flexibility. There was very specific language from the department when the program flex requests were made, because they requested flexibility for at all times, they requested flexibility from the ratios, and none of those were granted because the department was very clear as a result of the legislation. They did not have the flexibility to make that kind of changes under the law.
Great, thank you. But
Can I make one quick comment?
one quick comment, yes, and then I'm going to go to Marty and then to Stuart.
I just want to comment for one moment about Boston Medical Center's quality outcomes. We're not in the bottom quartile in Massachusetts in staffing, first of all. We have excellent quality outcomes across both nurse-sensitive metrics and others. We are in the best 20% quartile, the best 20% in the country in compared to academic medical centers for mortality, which I think is the quintessential quality metric. So just wanted to say that.
Great, thank you. Okay, Marty.
Thanks, Wendy. So I have the privilege of being the behavioral health representative on the commission, following in the footsteps of the secretary. And so obviously my concern is, what does question 1 mean for behavioral health services, particularly psychiatric inpatient and substance use beds? The Mass Association for Mental Health, a nonpartisan, non-provider mental health advocacy group that I have tremendous respect for, recently wrote, and I'll quote, "There's a shortage of psychiatric nurses in Massachusetts that keeps 150 already licensed inpatient psychiatric and substance use treatment beds empty because hospitals cannot find nurses to staff the units. Without a pool of trained psychiatric nurses, hospitals will be forced to close existing beds to redistribute nursing staff to remaining beds to meet the staffing ratios imposed by question 1. That includes freestanding units, but I also worry about psychiatric units in community hospitals where the margins are so thin that may be a first place where people look to close units. We have a tremendous mental health access problem. We have the need for more psychiatric beds. I'm worried what the impact of this initiative will be on those beds. And I have to add, I'm also concerned when I'm not sitting here, I'm a funder of lots of community programs, what this will mean to group homes, school nursing programs, community health centers that are having a really hard time attracting nurses now. And if there's a premium that hospitals are now going to pay to attract new nurses to fill these ratios, what does that mean for community programs? Judith, I know you're a psychiatric nurse, so I'll ask you to answer.
Sure. I just want to add one caveat to that. So we recently granted a license to a state-of-the-art psychiatric unit for kids on the spectrum, which is probably the highest percentage of individuals who are boarded. You can't open because you can't find any nurses.
So I am a psychiatric nurse. I was practicing yesterday on 3 psychiatric hospital units. And a couple of points about psychiatric nursing practice quickly. One of the reasons that we've all had difficulty, and Dr. Altman was my mentor and wrote the premier books and studies on the nursing shortage. So he knows better than I that shortages are largely driven by working conditions. And my work finds that the number of injuries and life-threatening injuries to nurses, and we have 21,000 lost days of work due to injuries to nurses in Massachusetts or workers in Massachusetts. A lot of that is concentrated in psychiatric hospitals and emergency departments. So we need to try to do our best to provide safe environments for nurses to work. That's number one. Also, I think, just based on my experience working with my students, that patients are sitting an average of 3 to 4 days in Massachusetts emergency departments. There's over 100 days difference in the wait time between California and Massachusetts in getting placed. When we walked into the unit, when I did at 6:30 in the morning, there were going to be 10 admissions. We pitched in and helped, but those beds sat open after midnight because they didn't have the nurses to bring those patients out of those EDs. I personally think, and I want to study this in my sabbatical, that if we are able to staff up the psychiatric facilities, make them safe, improve the quality of work life for those nurses, then I think that wait time in Massachusetts EDs is really going to drop. That's the conundrum we're in. It's like, how do we dig ourselves out of these holes? If you staff it, they will come. McLean Hospital does not have a problem staffing. It's got great working conditions. So do the partners' facilities. But the problems with some of the facilities that you've had to investigate, Secretary, we know that they're very poorly staffed.
But I'm talking about a state-of-the-art, brand-new, freestanding psychiatric hospital for children on the spectrum. Can't find a nurse. Brand new, state-of-the-art. Can't open. It was supposed to open last May.
So I would
I
like to
appreciate
talk
that.
to you about that, because
And
we
we've
have
closed, as you know, we have
Yep.
closed psychiatric hospitals that did not meet good quality standards, which should free up nurses for others.
Right.
But there are licensed capacity, but not staffed capacity in psych because of the inability to hire nurses. So it's just not a debate, it's just like a reality.
Right, so let me tell you how, and Dr. Altman can remember this, how we addressed chronic shortages in certain sectors of Massachusetts hospitals. We created a workforce initiative. We recognized that back in the 80s and 90s, when we had rate setting, we recognized that there were problems getting certain levels of hospital staff in certain types of units. And we created a worker program where we paid for, and we reviewed, I was on the committee that reviewed these RFPs, to get nurses into settings, state hospitals, which we had a lot of back then. I was a beneficiary of one of those scholarships to go and work at the Lindemann Center. So we can do it. We can do it if we provide incentives through public health. We have many of our graduates in our psychiatric nurse practitioner program got their graduate education paid by National Public Health Service grants. They are all working in those types of settings. And if we create that here in Massachusetts, if we identify those settings as public health service sector facilities, those nurses will go to be employed there.
Thank you, Judith.
Can
I
Nancy
actually,
comment on my question?
on your
Because-
question,
Yeah, about the impact on, your sense of the impact on psychs.
on
services.
psych, yes.
Well, I'll agree that I'm worried, as you stated, about the focus and sort of the magnet of acute care and pulling nurses away from other settings where we have been working so hard to push patients into those community settings, and I think that's a big risk. It's been identified by the community health centers and a lot of the other programs. So I agree with that. And I guess the second thing I would say is that I want to keep focusing on our conversation on what this ballot question would mean and how it is written. And I think the reality of the psychiatric hospitals is that they've identified they would have to close 1,000 beds, and I can tell you that those patients will be in the emergency departments because they have got to get care somewhere.
Thank you. Stuart, you had a question, you're next. Then Tim.
So I have more of a question, but a comment. So as David Sells pointed out, the Health Policy Commission is committed to doing an objective, data-driven as much as we possibly can. You raised, I remember it was Schindel much more, if I remember correctly.
Yeah, I was the thorn in your side when
okay,
I was
I just-
much younger and
I
more
do
beautiful.
Sounds more like less like a thorn.
So you raised a number of issues that I consider to be very important. I mean, yes, we really need to be concerned about cost, and we've had a very serious set of cost discussions yesterday and today. But we're also very concerned about access, and particularly access for low-income populations and the behavioral health. To the extent that we need to be doing more and understanding this issue, I'm going to commit us to continue to focus on the issues you raised. The problem we faced is in a very short period of time, faced with this ballot initiative, which we had to analyze given our legal mandate, We did the best job we could, and I will take nothing away from the quality of the staff report. They did everything that they could. But that doesn't mean, and as David has pointed out, that we did everything. We're more than willing to sort of look at this issue, particularly when it comes to this issue about where you pointed out where we're behind California or other parts of the country. Regardless of how the ballot initiative turns out, I said I'll make a commitment for us that we're going to continue to study this and make sure that to the extent that we find out that there are serious problems in our state, we're going to identify them. But given what we were faced with, given the responsibilities that were built into the initiative, as our general counsel pointed out, we had no choice but to analyze it the way we did. But that doesn't mean that there are not problems we need to address. So you have my commitment that this issue is not going away, regardless of how the ballot
Thank
works.
you.
Tim, and then David Cutler.
Thanks. Thank you. A little bit building off what the chairman had to say. You know, I've been pushing for a long time as a commissioner of the Health Policy Commission to have a conversation about the role of the healthcare workforce in increasing quality and reducing costs. I didn't think this was going to be the forum in which we'd be having that conversation, but I think it's an important one. And, you know, the role of the healthcare workforce, you know, RNs and other healthcare workers, and reducing overall cost and engagement in those conversations is a really important one. And so, you know, I wish it was under different circumstances, but, you know, it is what it is. And I have to say, I feel like clearly we've seen there are differences between the law, the ballot question here and the law that was passed in California. Clearly the process by which the law was passed in California is different than the process by which it's occurring here. And clearly, I think the proponents of the ballot question have been trying to have some of these issues addressed, both through the legislative process and contract negotiations and others, and feel that their issues have not been addressed through those processes. So I think it's an important question for us to continue to debate and discuss. I mean, clearly, the role of the entire healthcare workforce in this care delivery system is important to take into consideration. A team-based approach that engages all healthcare workers, I feel, is a really important one to have. I think this conversation really comes down to, and I'm looking for more clarity on, the current number of RNs we have here. I think you mentioned the graduation rate, and how many are we graduating? What percent are leaving the state? What percent do you suggest are going to stay? I think that's clearly has a big impact on what the overall cost of this would be and how to find and fill the positions. And clearly, representing workers at Boston Medical Center, we know that there's been an attempt to try to hire RNs. We've seen it in other areas as well. So I think it's a good question to grapple with and better understand of what is the current workforce look like. Where did California have to find nurses to fill the ratios? And then also the major disagreements around what is the wage increases that are going to occur. I think it comes down to those two simple questions. Where are we finding RNs? Do they currently exist? I think there's two different opinions on that. And what are the costs associated with trying to hire them, and what are the wage implications of that? And we've heard very different stories about that. So I can understand why voters right now are very confused in Massachusetts, but I really would like to drill down on where are the nurses coming from? Are they in the state? You know, are we graduating them? And it's those state fee and issues that I think are really important that you addressed. Do we have to train new ones? We have to find out of states, you know, all the items that were listed. And then really, what does that number look like? And then what do we really believe, or what are your thoughts about what the costs will be in terms of the wage increases?
So I'd like to start with the numbers that we know, because that comes from the Massachusetts Board of Registration of Nursing. And I'm going to start with baccalaureate graduates, because those are the folks who tend to be who are being hired in our acute care hospitals. So every year we graduate about 2,400 baccalaureate graduates. It's close to a little over 3,300 total. That would include associate degree graduates as well as master's prepared NPs. So the real number in terms of every year is about 2,400 baccalaureate grads that we're talking about. Now, I can tell you, because I'm the faculty advisor for the Massachusetts Student Nurse Association, they are having a very hard time getting jobs in Massachusetts. And the annual survey by the National Student Nurse Association validates that. I sent the Health Policy Commission, I sent Dr. Auerbach their survey from last year, the new one for 2018. They close it in September. That ought to be ready in a few weeks. But the trends, she told me over the phone, the executive director, look like California and Massachusetts are having, those graduates are having a harder time finding jobs in Massachusetts. It's going down again, where it's going up every place else. It's a shorter time from when they graduate to get a job every place else in the country except here and in California. So the other part of your question had to do with, I think, where else are we going to get that difference? Because we're going to have to increase somewhere between 2,000 and 3,000 RNs, according to the HPC report. That's apart from the ED. We have a lot of part-time nurses, and they would love to work full-time. I mean, the number of part-time nurses nationally is about, the figure that I pulled out using the AHA data was 19%. Now, so we are above California, but we are one of the states with the highest part-time labor pool in the country. And so we could potentially, I think, pull from those nurses as well, part-time. Wages, I really strongly feel that the wage rates are inflated because California initiated this ratios when we were in a severe nursing shortage nationwide. Dr. Altman, I mean, you talked about this. It was horrible all over the country, and we had to improve the working conditions. We had to improve nurses' wages. We don't have a nursing shortage. We are, HRSA, Health Services Research Administration, expects that Massachusetts, and the HPC report said this, is going to have a 2% surplus by 2030. So we are going to have a surplus. This is a federal study in 2030. So we have the supply here in Massachusetts. We have the highest number of RNs per population of any state in the country. So we do have a problem with sectors. And we've been there before with this problem. So I don't want to dismiss that at all. And I think we have a way of dealing with it because we actually were successful putting our heads together with rate setting and doing the best we could. We did.
Judith, I'm just going to ask you to cede the floor to Nancy.
I'm just going to add one more thing to make sure we have the full picture. So we have 1,200 vacancies right now in Massachusetts. We have one of the oldest workforces in the country with 51% of the nurses over age 50.
We prefer the term most mature.
Thank you, sorry. Most experienced, seasoned. But 4,500 nurses retire annually in Massachusetts. And I'm going to agree on the 3,300 new grads, but we would be already in a deficit position if we hired every single one of them just with the retirements and without the additional 4,000 or 5,000 new nurses needed with this law. And also, I would just also like to add that these issues are very regional too in terms of where there are available staff.
Great. Joanne and then Vicki.
Sure, I'll speak to a few things. One is regarding the HRSA forecast, Health Resources and Services Administration. I don't remember the Massachusetts numbers exactly, so I'll go with the 2% surplus. Is that Massachusetts or national? That's Massachusetts. So when you're trying to look 15 years out, which is basically the range of those forecasts, 2% is kind of, balanced, looks pretty good. The projected impact from all the analyses that I've seen, including I think yours, is that the number of nurses that would be needed is more than that 2% buffer. So there would need to be more graduation growth here. Now, how Massachusetts how California handled that was we already had a shortage. There was a lot of effort put into growing programs. A lot of traveling nurses came in temporarily. With the current issue for California, and I can't speak to Massachusetts, on new graduates not getting hired, which apparently is happening in a state with supposedly where there might be more demand versus less demand. Some of that is the skills issue, that the people retiring are clinical experts in their fields and new graduates take a while to ramp up. So there's a challenge there that I've been taking hospitals, speaking with them a lot in California. We just did regional meetings about how to address that problem. I do want to speak briefly to the wage analysis that we did for California, because that has clearly been brought up multiple times. The research for that was again led by Barbara Mark at University of North Carolina. And we looked at multiple different data sources and looked at how much wages changed in California compared to other states during the same time period. So everybody's wages were rising because there was a national shortage of registered nurses. California raised even more pre-post ratios regulation than the rest of the country did. Depending on which data source you used, it went for anywhere from 0 to 8%. The 0% was more that there wasn't enough data to get a precise estimate, as opposed to there was no effect. But if you look at the table that David presented of the costs and you subtracted out that wage increase piece, you would get $400 million to about $670 million being the range from A to B of what the cost increase would be straight from the hiring and the other components, and not including psychiatric emergency department, or no, that does include psych, not including emergency departments and the cost of onboarding and those processes that were already delineated that we couldn't address. So even if we take the whole wage increase out of the story, there's still significant numbers there that, we should not dismiss the entire projection over that one piece. That's why it's broken out for you.
Thank you. Vicki?
I just wanted to talk about the California experience with implementation. And what happened was, as working conditions improved with having additional registered nurses in the workforce, older nurses stayed for a longer period of time. So we saw delays in retirement. The other thing is that those nurses who came from other states, many of them stayed. The conditions were better, they wanted to be there, and so it was really something that really changed the way we brought nurses into California. As far as the new graduates go, we were very excited to bring in large numbers of new graduates into the hospital so that these experienced nurses were actually able to provide the, be resources and provide their expertise before the nurses retired. So, we didn't have a problem. The part of the wage increase also was related to the fact that hospitals were competing for registered nurses, but the problem was created by the hospital industry themselves. I looked at the RN workforce, national from 1994 through to the current time. I looked at the increases in inpatient RNs during that period of time, and both California and Massachusetts prior to that time saw decreases, significant decreases in their RN workforce during the early to mid-90s. What ended up happening when you go fast forward to 2016, and you should note that is on a backdrop of looking at all other states, and they didn't have that decline when you're looking at the national data. And particularly if you take California out of the mix, you saw continued growth during that period that they were laying off registered nurses in California because of managed care penetration and changes that were being made. Now, when you go forward to 2016, California had 70% more RNs in California in the inpatient setting than since 1994. National levels, if you take California out of the mix, and if you keep California in the mix, are up in the high 60s. Massachusetts, in comparison, is 49%.
Great, thank you. David?
I have a question for Deb DeVoe. So the estimates that David Auerbach presented are that spending at the typical hospital would go up about, let's call it 3% or so. And maybe it's a little lower because the wages don't go up, or maybe it's a little higher because they have to hire more and so on. Mass Health probably doesn't pay more, maybe Medicaid pays a little more, so whatever. So maybe you're looking at 4 or 5% on average. With some hospitals, as we've learned, going up more. That is, the need to hire is different in different institutions. So you're going to get some hospitals coming to you saying we need a 4, 5, 6, 7, 8% price increase in order to make this. Tell me how that conversation plays out, because you're also under a 3.1% target. So do you say, I'm sorry, I can't do that? Do you say, well, maybe I can give you 1 point, but I got to take it away from someone? Tell me what happens in that conversation, I guess. Guide me through that conversation. And a related issue is you sort of walked up to the edge of saying, Blue Cross Blue Shield does not like this, but you didn't actually say that. And so I want to know if that, did I hear you correctly to imply?
Good point.
To imply that
Blue Cross
you,
is not taking a position on the ballot question.
okay.
To answer your question. As far as those conversations that you're framing, part of the context is really going to matter in terms of paying for additional costs. At this point, we're not seeing a direct connection to an improvement in quality. And I can tell you that while I fully appreciate the conversation that's occurring about access concerns for certain types of patients, and I understand that, we're not hearing from our customers every day about the quality or access in Massachusetts. It's generally experienced as very good. What we're hearing about from our customers is cost and affordability. And they are viewing our job as primarily having their financial back right now. They're not expecting Blue Cross to be advocating for additional increases in quality and access beyond what we've been able to achieve in Massachusetts. Understanding that there is still room for improvement, and I respect the points that have been made earlier about certain types of patients, that is not what we're hearing about from our customers.
Thank you.
Mary Lou.
Judith, would you just, so 3,300 graduates a year?
Right, total AD.
And how many passed the licensing? I'd love to say 100%,
That was,
but that's probably not true.
the number I added up was the one that, on a table that had passed.
It's like 80, yeah.
Yeah.
The number I had when I looked was about 80 to 84%. I'm sure BC is 100%.
Yeah.
But it's about 84%, so it'd be like 84% actually passed the licensing exam. And then I just want to clarify one thing, and perhaps it's minor. When you looked at me and said it was a person from the Department of Public Health who was on your group, it was a former employee. So it was not someone who was there in their official capacity with the Department of Public Health because they were no longer working for the Department of Public Health.
Okay.
So I just want to.
Thank you for that
It's just
clarification.
important to be precise on these things. Thanks.
Right. Other specific questions? Yes, Ron.
If I understand it correctly, let's say you're graduating around 2,500 annually, and Nancy has a shortage of around 2,000 statewide.
1,200.
1,200 for the state,
Today, yes.
right? And what about at Boston Medical Center?
We have about 130 openings right now.
130 openings. And you claim that it's really difficult to get jobs in Massachusetts. Now, if Boston Medical Center has 130 openings, what are the openings statewide? And why is there an issue with that?
So I would love to know where those openings are, and so would our nursing students. I mean, we graduate most of our students in May, and that's when they're going to be looking for jobs. They are not being interviewed for positions until they pass the nurse licensing exam. So there will be a group presumably graduating in December that could potentially fill some of these positions. In the meantime, though, I think that there is an opportunity to shift some of those part-time nurses to full-time positions. And as I understand it, and again, I may have the exact numbers wrong, is that there's some consolidation going on at Boston Medical Center. And there's maybe the possibility that some of the nurses who will be shifted over to another unit in the hospital will be available for some of those positions. We have had BC students hired at Boston Medical Center. They were hired this summer. So, I mean, our students are certainly going there.
And Nancy, did
Maybe
you
I'll
want to
just
respond?
Make a couple comments. One is, I have seen in my career that the part-time, full-time shift is very economy-driven. And we are always giving nurses who work in our organizations, no matter where you are in Massachusetts, the opportunity, if they're part-time, to go to full-time. I don't think there's a nurse who wants to be at full-time who doesn't get a chance to be that in the next couple of months if that's what they want. So I think in terms of that, part-time is not an issue. And in terms of the hiring of the new grads, nobody loves new grads as much as I do, but you do have to pace in different areas how many you can take on at a time.
Right. Vicki?
Yeah, sometimes we can learn from history. And when I graduated from nursing school, the hospital hired me before I got my license. I wasn't able to practice as a registered nurse, but I had completed my training, and they had an internship program, which basically you oriented to the hospital. You got used to the patient care area. You were basically brought in at a lower rate. It wasn't the same rate as a registered nurse, but they didn't wait until after you had passed the license in order to start introducing you to the practice in that particular hospital. So that's always an option. I mean, you can, if new graduates, during the nurse-to-patient ratio implementation, those hospitals were going to nursing programs in advance. They were letting nurses know that they had training programs for them, and in fact, that they would train them into specialty areas so that they had the opportunity to select specialty areas.
Thanks. I'm going to, we just have a few moments left, so I'm going to wrap it up with a final question that's really, I think, directed both at Joanne and Vicki, but certainly feel free to pile on. And that is that given both the similarities and the differences between the California approach and the proposed Massachusetts approach, what are the really positive things that, should this ballot initiative pass, we in Massachusetts should pay attention to that happened in California? So we know we're all a little anxious here about the minuscule time frame we have to implement this, 6 or 8 or 10, 6 weeks, 7 weeks if it passes, whereas you had 5 years. Maybe there's a lesson to be learned there. I'm interested, and I think the commissioners would be interested in, what have we learned from California that would be helpful to us in crafting the next steps? And maybe the next steps, I was just going to say, maybe the secretary has the next steps, but you'll do just fine. Kind of, maybe we think about, should this really be housed, should it be housed in the Health Policy Commission? Should it be moved over to the Department of Public Health? I think there are a lot of things you've learned over time, Joanne and Vicki, out of the California experience that you might share with us, partly so we end on a positive note, but partly because I wouldn't want to leave this very active and thoughtful panel without you being able to give us 30 seconds of wisdom from each of you about what should we take away from this. Joanne, why don't you begin?
Okay. So there were several, I think, well-documented things that one would view as beneficial. One is that the poor staffing hospitals were forced to come up. The study that we did, funded by the California Healthcare Foundation, we did a survey of hospitals that was voluntary. We had no sticks to make anybody respond. But we were honestly surprised at how bad the staffing was for a few of the respondents, especially on night shifts. So when we looked at those data, we said, some of these hospitals, something needed to push them, perhaps. It wasn't clear that those were going to voluntarily change. For a lot of hospitals, they were probably doing reasonably well or quite well or very well already. But for those ones that were on the tail end, it moved them and it forced them to move. We do surveys under contract for the Board of Registered Nursing, and through that period of time, registered nurse satisfaction in California with the adequacy of staffing and with the time available for patient teaching improved. We had no comparison to other states over time, but it was consistent with what the study that Linda Aiken led found, comparing California to other states in a single year, that perhaps California nurses were getting happier and more satisfied with their work and had more time for some of these things. So that shows up pretty consistently. There was the more recent paper that was led by Patrick Romano from UC Davis, who is a fabulous researcher. Actually, the lead was, I think, one of his students or one of his advisees. Lee is the guy's last name, that documented lower occupational injury rates, which was a very well done study, a very interesting and I think important finding that's often been overlooked, although Vicki mentioned it, which is important. I think also one of the impacts, and this has been alluded to in the discussions here, is that even though we had a deep nursing shortage, it wasn't until the regulations passed that at that time Governor Davis and then subsequently Governor Schwarzenegger both dedicated significant amounts of money to increasing nursing education in California. Prior to that, the governors had kind of largely ignored it, including Governor Davis previously. And Governor Davis announced the Nurse Workforce Initiative, basically at the same time the draft ratios were announced. And then Schwarzenegger had a different name, the Nurse Education Initiative, I think it was, that he then put into place that was essentially the same thing, but called it something different, that was his program. And so it wasn't, to some extent, they ignored the education growth, especially in the public sector, as an important issue, and that schools needed to have more state funding to expand public education. And that, so from that standpoint, I think there also was maybe this unintended positive benefit, is that really helped lead our nursing programs to double the number of graduates in the state. That's had a lasting impact for us.
And that's helpful, because I think, Stuart, that goes back to partially answering your question of what could we look at in the future?
Let me, hey, if you're going to do that, you got to look the other way around. When you compare Medicaid, or in the case of California, Medi-Cal spending compared to Massachusetts, so you're dealing with one of the lowest, if not the lowest paying state in the United States.
Yes, we're bad.
No, you're very bad.
It's very low.
And so I can understand why some of your hospitals that are primarily treating Medi-Cal patients were in deep trouble.
Oh, absolutely. When you ask for positives.
Much as I said, I think we need to learn more about a number of things like that. The problem with the answer to your question is that Massachusetts is not where California was in the mid-1990s. Am I correct?
Yes,
All right.
it's true.
So the idea that somehow we could learn today in Massachusetts what California had to go through in 1996 up through 1998 and then up to 2002, much as that sounds like a nice question, it's really not a very relevant question. What we need to do is really, as I said, we need to do a workforce study by institutions, but I don't think we can learn all that much in 2018 about what California was like in 1995. I'm sorry.
No, fair enough. I mean, I think there were some things to learn there possibly, but as I said before, the regulations proposed here are different, the context is different, so some of the things that we found and did not find in California may or may not occur here.
Right, and I think the contribution that you've made to our study has been very helpful in informing Dr. Auerbach's team as we have, coming back to my opening comments, looked at the cost. And that is indeed our number one priority here. Even those cost ranges from 600 million to 900 million in there were well informed by the California experience. So I appreciate your helping us to finish on a positive note, and also thank all of you for your input today, because it's very helpful to us in understanding how that nurse shortage is going to ultimately drive the cost of this ballot initiative and if passed, the cost of healthcare in the Commonwealth. So thank you very much for your participation, and we'll look forward to seeing you again.
Again, I want to convey my thanks to the group. This was a wonderful panel. Wendy, I want to thank you completely for really putting together a great. All right. So we're now reaching the bewitching hour with respect to the closing of these 2 days. We have a few minutes, so while we had the benefit this morning of summarizing yesterday, perhaps anybody would like to make some closing comments with respect to how, what you might have taken away from today. We clearly touched on 2 very critical issues of pharmaceutical pricing. I'm particularly anxious to even learn more about what other states are doing in the pharmacy area, but also, there's a lot going on in terms of Medicaid and the structure of the Medicaid program in different areas. There are, much as Trish did a wonderful job, there are a number of states that want to change their Medicaid program and introduce things like work requirements. What are the implications of that? What happens to, this new ACO initiative that Massachusetts is pioneering, or other states doing anything like that? So I think we have more to learn from other states that will keep us busy, I'm sure, David, and you're going to continue to do that. With respect to drug pricing, clearly transparency has value, and we need to do more of it. But I think we all recognize that transparency by itself will not really have pretty much of a fundamental unless there are other changes. I think we learned how much we don't know about things like the rebate system, how it works, how it doesn't work, who benefits from it. We clearly need to know more about that. But all told, I think we learned a lot. Again, I want to commend the staff. I know how much you guys have worked to make this thing something. And, we just stand up here or sit up here and act like we know what we're talking about. But the reality is you guys did all the work. So good job. Anybody else want to chime in? David, would you like to say something?
Thank you, Mr. Chairman, and thank you, board members, for leading a really excellent discussion over the last 2 days. In some cases, we get to set the table, but you really have to deliver and have a great discussion, and I think you've given us a lot of homework. I feel like we have a number of new studies that are on our table for the next year, and we look forward to really continuing this agenda forward. I do want to just recognize that we did have a number of elected officials who were with us over the last 2 days. Really appreciate their engagement. Representative Dykma, Representative Barber, Representative Garlick, Representative Benson, Representative Hecht, and of course, Vice Chair Roy from Healthcare Financing, who I think was here for literally the entire 2 days. So thank you, elected officials. I know there's a tremendous amount of legislative staff who are also in the room and who are following online. Again, we look forward to working with you in the next session on advancing some of these policy solutions. So thank you, and a great cost trends hearing.
Feel free to take an hour off before you get back to this agenda. All right. We are adjourned.
Thank you.
Thank you.
Clap for adjournment.
Great job.